I'm Bruna Ventura, and I'm here at the 2022 BRASCRS meeting, having the pleasure to interview Dr. Ike Ahmed from Canada. Thank you so much, Ike, for making the time to come to the meeting, to come to BRASCRS. It's always a pleasure to have you here.
Thanks, Bruna. You know, it's a pleasure to be here, boa tarde, to be in this great city of Salvador at BRASCRS and to see great people like yourself promoting our great field. So thank you so much for having me here.
Wonderful. You had so many interesting topics in the meeting. One of them was speaking on MIGS and the cataract surgeon. Why do you think cataract surgeons should consider implanting MIGS?
You know, traditionally, cataract surgeons perhaps are not thinking about glaucoma surgery. It's generally been within the domain of glaucoma specialists. But it's such a great synergy with MIGS and cataract that I think it's worth considering. Of course, many patients who have cataract have glaucoma and are on pressure medications. They don't need to have an aggressive trabeculectomy. But we're showing more and more data that combining cataract with MIGS gets patients on less medications, lowers pressures, and reduces the need to go on to further surgery. So it's a one-time opportunity to consider to treat some of the glaucoma at the time of cataract surgery with a relatively safer procedure like MIGS. And I look at this example like toric lenses. We can correct astigmatism with cataract surgery and toric lenses, and why not do it at the same time? When you have glaucoma and cataract, why not consider at least addressing both cataract and glaucoma at the same time in your hands and do it in a way that's safe and that can be effective.
Wonderful. What would be some important topics for us to mention for the cataract surgeon that's considering MIGS?
So I think a few things are important. Obviously, we have to have a good expertise on glaucoma. So understanding imaging, visual fields, severity of disease. For example, we find MIGS is more effective earlier with less severe patients. Severe patients don't respond as well. And of course, gonioscopy. This is really important, of course, to have a good understanding of the angle, both preoperatively and intraoperatively as well. I think if you have those aspects comfortable, you can move on to sort of now looking and working into the angle. There are many devices that are available, many devices that you can use to stent, to dilate, to cut. You can choose your best approach, whatever works best for you. They all have differences. But those are the general essences of doing this. Anybody who does intraocular surgery, though, and can view an angle can learn to do intraocular gonioscopy. And I think that's what we're seeing around the world.
Wonderful. And one last thing that I wanted for you to mention. When you're doing MIGS as a cataract surgeon, me, Bruna, and let's say I align the toric IOL, I'm not comfortable in closing the pupil, re-injecting viscoelastic to then insert the MIGS. So how do you do it to make sure that the alignment of the toric IOL is not offset?
Yeah, so I mean, in the past, maybe there was a thought that you have to constrict the pupil to view the angle better. But when we're doing it in the OR under viscoelastic, you have more than enough space to view your angle. So there's really no need to use any kind of meiotic or constriction. I've never needed it, so I don't do that. And if we can do MIGS either before the actual capsular excis or you can do it at the end, but we don't need a meiotic. I think that's one important thing. What we need, though, of course, is a great view. So using proper intraocular gonioscopy, we need to use the right hand positions to do our work, and really there's no need for any kind of meiotic. And post-operatively, fortunately, most patients are pretty routine as far as the follow-up. And I think it's choosing the right patients, having the best view during the procedure, and then choosing the right device or procedure to do your MIGS. So I see MIGS growing. Obviously, there should be careful utilization of procedures and appropriate use of them. But there's no reason, in my opinion, why cataract surgeons don't have the skill set or the knowledge to treat glaucoma in a safe way by doing MIGS. So I hope it'll continue to grow around the world, including in Brazil. There's low cost and different technologies available depending on the patient and the environment.
Wonderful, wonderful. Thank you so much, Ike, again for this interview. Amazing.
Thanks, Bruna. You're the best. Thank you.